Bismillahirrahmanirrahim. Thank you very much, the Harvard team, especially Saad Ilyas, for letting me speak on my favorite topic, tuberculosis of the spine, which is a bane in our lives. It's so frequently present in this part of the world that not to know about this, you cannot practice spine surgery in this country. The The biggest person in our part of the world who passed away because of TB of the spine was the founder of Pakistan, Muhammad Ali Jinnah. And he refused to be taken to the UK where streptomycin had been discovered because he said Pakistan could not afford this kind of treatment. And in addition to the great Qayed, these are some names of big people who died of tuberculosis. So, unfortunately, it is also known as the captain of the men and women of death. Since time immemorial, ever since the Egyptian mummies were discovered, the deformities found in their spine are still to be seen in this part of the world. This is a child presently presenting with TB of the spine, and untreated severe kyphosis has occurred in this child, and the resilience is amazing. They still are neurologically intact most of the times, unless the deformity is left totally unaddressed, and then they present with late paraplegia. Percival Pott discovered in 1779 the spinal TB and was called Pott's disease. My people are very poor, but their innovations are unimaginable. Look at the stretcher made out of a bed in this poor person. His wife is suffering from TB of the spine, and this is how he's brought her to the hospital. A three-wheeler rickshaw, people are brought in this. People are carried, helped, and brought to the emergency with this. And a lot of them present on stretchers in horizontal fashion. And once they are dealt with, they, by the grace of God, walk back. This young lad was studying in the United States in a university, and in the university championships, he had defeated Roger Federer in tennis. But fate had something else for him, and he developed cervical spine TB, became quadriplegic, and then presented to us with these bed sores, which we dealt with. TB, unfortunately, in our part of the world, because of poor medical practice, because of poverty, and lack of availability of nutrition and anti-tuberculous drugs, 25% of TB, and I'm sure it's more than this, the record keeping is not brilliant in this part of the world. 25% are multi-drug resistant TBs, and they do not benefit with simple chemotherapy alone. As per WHO, 50% of people who get anti-tuberculosis treatment do not recover in this part of the world. The conservative management is through braces and chemotherapy. And the main champion of conservative management is a gentleman called Tully from India, who has a series of 900 patients treated under supervision with anti-tuberculosis treatment and in hospital, and they significantly recovered. But unfortunately, we cannot do that. We cannot admit and treat patients under supervision because the workload is so tremendous. So our threshold for surgery is quite low. The indications for surgery on which I'm going to be focusing on, 95% of the TB disease is in the anterior column of the spinal cord, the vertebral bodies, and only 5% is posterior. Unfortunately, majority of the surgeons operate through laminectomies in a disease which has damaged the anterior column, thus worsening the patient's prognosis. So we see patients with huge paravertebral abscesses, collapse of adjacent vertebrae, and if it's more than 50% of collapse, we operate. If there is any neurological deficit, we operate. And in disease, multi-disease resistant TB cases, we operate. And we treat them to prevent further complications because the late onset paraplegia carries the worst prognosis. What are the factors governing surgical treatment? You aim for stability of the column, you aim for the alignment, you aim for the debridement of the abscesses, thus restoring biology, and ultimately you hope to achieve near normal function. And these are the principles laid down by the AO group, who has done extensive work on spinal surgery. So these are our guiding principles. As I mentioned, 95% of cases are anterior. So any pathology which involves the anterior column ought to be managed anteriorly rather than going through the back. So we have a series of more than 2,000 cases from C2 to S2, and we've dealt with them through an anterior approach and stabilized the anterior column with a cage which is locally made, handmade of titanium and costing $30. Unless you restore the anterior column, you will not get function and alignment. Look at this crane. The weight at the front is the anterior column, and the cord at the back is the posterior column. Both are essential for adequate functioning. And if one column is gone, you need to restore it to get the function back. Euler's principle of slender columns: if one column is damaged in the middle, the whole column collapses. And this 9/11 picture will remind you of this principle. And we follow this to the letter. This states that if the vertebral column anteriorly is damaged, vertebrae are collapsed, you get kyphosis. And unless this is replaced and you restore this anterior column, you will not get adequate function. So you restore debride, restore the anterior column, and since it's a gradual deformity, there's no need to go to the back and put in screws. So I feel, and we've proven this by our experience, that it is an overkill, probably a company sponsored indication. The implant that we use costs less than one transpedicular screw, and only 5% of cases have posterior TB. And these are the cases where justified in just doing the laminectomy. And if you do not damage the lateral masses or the facets, there's no need to fix them either. Laminectomy in 1956, Seddon described that for anterior disease, if you do a laminectomy, it's a crime. You worsen the prognosis of the patient. Current recommendation is combined anterior and posterior approach. We found that this is an overkill, not usually necessary. Costotransversectomy for drainage, we usually don't need to do this. If at all there's a lot of liquid collection, we aspirate it with a white bore cannula under image intensifier, but we rarely do this procedure now. And once we do a thoracotomy, because in the thoracic spine this disease is more common, secondary to pulmonary TB, we take the rib and restore the iliac crest from where the graft is usually taken to fill in the defect cage. The advantages of anterior approach: basically, remember, the disease is anterior, so you need to sort it out anteriorly. So you do adequate drainage, you remove all necrotic and dead tissue, and you adequately decompress the spine because the compression is usually anterior. You take the tissue for histology and culture, and the kyphosis can be corrected with an anterior cage so that the normal restoration of alignment and subsequently function. And since the cage is filled with bone graft, the fusion is also achieved. There were some reports which said that you need to put graft around the cage, but we've found over the years that if you pack the graft inside the cage, you don't need to put graft around and you get good fusion. This is our case series from the PEG to the S2, and we are very happy with the results. We usually do not give them any external splints except for a collar in the neck and a lumbosacral corset. Thoracic spine, you don't need any external support. These are the areas which we've found to be most significantly involved in TB. And TB of the thoracic spine by far is more than half the cases that we've dealt with. But we've dealt with across the spine, and all have been treated with our standalone cage. Time since presentation and coming to the hospital, this varies. And majority of our patients come to us between 3 to 6 months of onset of symptoms, and TB causes paraplegia or quadriplegia, and the results are the best compared to trauma and other pathologies. Or if you adequately decompress and stabilize, they do recover significantly. Quickly show you some examples. This is the MRI showing C2-3 tuberculosis with significant compression. We went anteriorly, and you see this on X-ray C3, and we put in a cage. Even though it's slightly angulated, but the patient is fully functional, and you can see there's full range of movement. It's 2 years down the line, and he's fully functional. Initially, my great friends of cervical spine surgery told me that you'll need to stabilize it from the back, but there's no need for that at all. The patient is very happily functional, back to his work, no neurological deficit at all. Examples, they present with neck pain, some with fever, and usually paraplegia, especially in the thoracic spine. And we do anterior decompression and put in a cage. It's quite stable, no need for any posterior instrumentation. And we have follow-up of 11 years, even more. The cage is not displaced, and it's stable in flexion extension views. Show you some examples of the dorsal spine, which is, as I mentioned earlier, more than half the cases that present to us, and they usually come with paraplegia on a stretcher in a horizontal position. And you can see the abscess around the spine. The MRI gives the whole thing away, and we operate and put in a cage anteriorly through a thoracotomy. We have no excess surgeons. We do everything ourselves. And this is after 4 years, 5 years, 6 years, 11 years. Fully healed, patient fully functional, full range of movement. We found that there's only 4 millimeter of subsidence in our cages, which are usually asymptomatic. Show you the lumbar spine cases. Even in the lumbar spine, the standalone cage is quite adequate. We've not had any significant problems with displacement of the cage. These are multi-years follow-up after surgery, 7 years after surgery. Another example of lower lumbar spine, a cage has been put in. We have cages as per the diameter of the spine, cervical, upper thoracic, low thoracic, lumbar, different diameters as per the spine. And we have different MRI positions, pictures to show you the destruction of the vertebrae. This was an L5S1, and we dissected this. You can see the iliac vessels. We separated that, put in this cage from L4 to S2. We were not sure if it's adequately in place, and so we got a CT scan with 3D reconstruction, and the patient walks asymptomatic. We started off before the cages about 20 years ago. We would either use the iliac crest or triple the rib graft, hold them with these cortical screws 4.5, put them in place, and supplant it with a plate and screw, and even they used to heal. But the cages made our life very easy, and we do not use any anterior instrumentation. These are the cages I'm talking about. The ends are serrated, they are made of titanium, and if you look at the ring on the top plan, you see this ring on either end of the cage. It is called the anti-subsidence ring. The serrations get into the bodies of the vertebrae, and these rings prevent them from subsiding. These are the cages in place, and on occasions when we have to revise, we've seen solid fusion inside the cage. Just to show you the amount of pus that we can get from these cases, you can aspirate these abscesses. Patients present quite late to us. And this is the game changer now for advanced vertebrae. This is the halo pelvic device invented by my able assistant professor Saad Ilyas, and we have done about 150 cases of these, mostly in resistant stiff scoliosis, in trauma of the C1-2-3 region, and mostly in children with scoliosis. It all started with this case, which has been published, of anaconda spine of the upper thoracic spine, secondary to TB. And look at this curve. So we put this patient in this halo device and we distracted it 4 millimeters a day. And when it was significantly straight, we did a thoracotomy in the cage, in the device, and we put in a cage. 8 thoracic vertebrae had to be sacrificed, and this cage was quite stable. Once we put it in, we took this device off. This is the halo pelvis device. We've also published this standalone cage in different journals, and we presented at the Global Spine Congress in Argentina, in Italy, and our papers have been accepted for the forthcoming Brazilian Global Spine Congress as well. So the take-home message is TB is very common. It's even spread to the West, secondary to AIDS and secondary to travel. 95% of cases are anterior column. It's secondary to thoracic TB. So our work of about a quarter of a century is that you attack the disease anteriorly. The hesitation for anterior surgery is the approach, and there have been reports published that if you do a thoracotomy, there is a significant morbidity. That is not true anymore. It's been published in the Global Spine Journal that if the chest tube is adequately functioned, you have no morbidity of a thoracotomy and standalone cage. So I would propose use this $30 cage made of titanium, a standalone device. You can significantly correct the kyphosis and no need for posterior surgery. And obviously you have to supplant it with anti-tuberculous therapy as well as calcium, vitamin D, and a high protein diet. So less is more, and it does the trick. Thank you very much.